Okay. Good morning, good afternoon, good evening. Buenos dias, buenas noches. Welcome everybody to the first plenary session. We've just heard a great opening ceremony with our different partners, and we're very, very happy to be here with you. So it's an absolute pleasure for me to facilitate this first plenary session. My name is Gerry Eikemans from the Pan American Health Organization. And I'm particularly pleased because this first plenary session of the International Conference of Urban Health is on the topic of urban health inequities. And I think this is really what will set the tone for the rest of the conference, because this, and it has come out very clearly in the opening ceremony, but it's one of our major challenges at this point in time. It's more important than ever. I'm joined by four great panelists. This is going to be a wonderful session, and they will all present their vision, their experience on the scale, the magnitude of urban health inequities, and maybe even more importantly, on how we could address them and how this particular moment in time is so important for recognizing and addressing the urban health inequities. So they've become really center stage visible. Also, they have been exacerbated throughout the COVID pandemic. We've seen that the COVID has disproportionately impacted populations in situations of vulnerability, including migrants, workers in the informal economy, or others who do not have social protection, people living in informal settlements. We heard about overcrowded housing, very often with limited access to basic services, including health services, food security, labor and social protection. And of course, the situation is often exacerbated by systemic racism. So the need to address the social determinants of health in cities has never been more urgent or more apparent, both for overcoming the COVID pandemic, but also to build towards a fairer, healthier recovery, or as the WHO director says, building better forward. Effective responses, of course, need to include community participation, inter-sectoral action, inclusive governance, policies pro-health policies that take into account health, the drivers or the determinants of health inequities. So without further ado, and thanking also everybody who's here and also our sponsors and partners, I would like to introduce our panel. We will have four speakers. The first one will be Dr. Ana Diaz-Roux. Then we will have Dr. Nicole Valentine. Then we have Dr. Tolula Oni. And then we will have Dr. Oramar Revi, correct? Yeah, so I will give a brief introduction before each speaker will give their presentation, and we'll start with Dr. Ana Diaz-Roux. Ana, dear friend and colleague, very well respected in our region and around the world, who will be speaking about urban health inequities, the magnitude and drivers. So Ana, if I may use your first name, she's the Dana David Dornsife Dean of the Dornsife School of Public Health. Also, she's a lead epidemiologist there. She's also the director of the Drexel Urban Health Collaborative in Philadelphia, in the US, and principal investigator of Salud Urbana in America Latina. We just heard the presentation on that. Before joining Drexel University, she served on the faculties of Columbia University and University of Michigan, where she was the chair of the Department of Epidemiology and director of the Center for Social Epidemiology and Population Health. She's internationally known for her research on the social determinants of population health and the study of how neighborhoods affect health. This work on neighborhood health and health effects has been highly influential in the policy debate on population health and its determinants. Anna was originally trained as a pediatrician in her native Buenos Aires, and she holds some MPH and a PhD in public health from Johns Hopkins University. Anna, the floor is yours. Please go ahead.
Thank you very much, Harry, for that very kind introduction. Let me share. Oops, no, I think can you see my slides?
Yes.
Okay. So thank you for that very kind introduction and welcome. Bienvenidos a todos. Thank you for joining us. You can see I am based in Philadelphia, as Harry said, but behind me you can see my home city of Buenos Aires, the great city of Buenos Aires. So, it's my pleasure to welcome you again, and I think it's particularly important that we're starting off this conference with a plenary on urban health inequities. I have, which is such a critical topic for urban health. So I will share with you a few thoughts and reflections on this topic, and I've structured it as 4 facts and their implications. The first fact, which will not be news to many of those joining us today, is that cities are characterized by both diversity but also inequality. This is an example from the United States showing the race and ethnic distribution of counties. From left to right, urbanization decreases, and you can clearly see that more urban counties tend to be much more diverse in race and ethnicity. They're, of course, also diverse in immigration status, and this can be a very positive thing. But unfortunately, it's also associated with large racial inequalities driven by racism and inequality, which I'll return to later. And here are some examples from the United States about the dramatic differences by race and ethnicity in various measures, various social measures, including wages, including education, and including even the kinds of schools that children go to. Now, these urban inequities have been growing and do not affect everyone equally. This is an example of that shows the dramatic increase in the number of high poverty neighborhoods in US metropolitan areas, almost a doubling since 1980. And in addition, intersectionality is critical. Someone who is Black and poor is 3 times more likely to live in a high poverty neighborhood than someone who is white and poor, for example, in the United States. And we have also seen an increase in wage inequality, a major driver of social inequities. This figure on the right shows that overall, the ratio of the 90th to the 10th percentile of wages in 2015 in virtually in all metropolitan areas is significantly higher than it was in 1980. And these ratios are quite remarkable, 5, 6, 7, 8, 9 times. Now, of course, these inequalities are present across the globe, and they are even more pronounced in lower and middle income countries. This figure shows the percent of urban populations living in slums across the world. And you can see that one piece of good news is that this proportion has decreased over time. However, the percentages remain unacceptably high, as you can see, nearly 60% in sub-Saharan Africa, well above 20% in almost all other regions of the world. And in addition, even though the percentages have been declining, the absolute number of slum dwellers has increased by almost 200 million between 1990 and 2014. Gini coefficient, which is a measure of the inequality in the distribution of income, is also a useful measure to look at in characterizing inequities. This figure from data from Latin America and the Caribbean since 1999 shows the Gini coefficients for urban and rural areas. You see that they have been declining, but they stabilized, and actually even the urban Gini coefficient appears to be increasing in recent years. And in fact, the Gini coefficient of income inequality is higher in urban areas than rural areas in 36 out of 42 countries with data. So urban inequality is a major characteristic. Social inequalities is a major characteristic of urban areas across the globe. The second fact, which is of course highly relevant to our conference, is that these social and racial inequities translate into health inequities. This is an example from the United States showing death rates by race and ethnicity in US counties. And you can see that although race and ethnic differences are large and present across the board, they are particularly large in urban areas. And life expectancy is also strongly patterned by things like income. This is another example also from the United States showing the distribution of life expectancy by household income in 4 big US cities. One interesting fact in this slide is that there are differences at lower income. So some cities seem to do better at in terms of life expectancy for lower income residents than others, even though the patterning is present across the board, something that we will return to later. Now, these inequities are also manifested spatially within cities in a very dramatic way. This is data from our Salubal study, which Olga Lucia Sarmiento introduced in the opening. So very large differences across the different parts of cities. This is an example from Santiago and Buenos Aires. And these are relatively large areas within cities, analogous to municipios or comunas. But if we zoom in and look in across smaller areas, this is an example from the city of Buenos Aires, we see even larger differences in life expectancy, 10, 15-year differences in life expectancy across the city. Evidence that something profound is happening in terms of the way in which social context is affecting health. Now, these health inequities are not only present within cities, but also across cities. This is, again, data from our Salubal study showing the relationship between life expectancy at birth by a summary socioeconomic measure for the city, which is a measure of city education, an imperfect measure, but one that is probably serving as a proxy for many, many different things about cities. And you can see clearly that differences across cities in life expectancy exist, and that these are patterned by city social and economic characteristics. Now, these inequities across and within cities are linked to many different types of health outcomes, and I'm going to show you just a few examples. This, again, is data from our Salubal study. These are rate ratios of youth and young adult homicides associated with city factors in 315 Latin American cities. This was a study that looks at a variety of city-level characteristics, both built environment and social environment, but I've highlighted how strongly predictive measures of the social environment are. City education and Gini coefficient are very strong predictors of homicide, even after we control for a range of other factors. This is another example on the right of factors associated with traffic deaths. Once again, a city social environment index is strongly associated, a better environment, social environment is strongly associated with lower traffic fatality, even after we control for a number of other important factors related to traffic deaths. Of course, COVID has highlighted, has made the issue of urban inequities front and center. Has shined a bright light on these inequities. And these are 3 examples also from Latin America, showing from left to right how positivity of tests, which is a proxy for incidence of disease, is strongly associated with living conditions, better living conditions. Cities in Mexico with better living conditions have lower positivity rates. In the middle, we see a similar pattern even when we look within a city. For example, the city of Santiago, the more advantaged the comuna, the lower the incidence rate. And sadly, we also see that vaccination is strongly patterned by social environment characteristics. Again, for Santiago, Chile, the comunas with higher educational attainment have significantly higher rates of vaccination. The United States, rich countries, no exception at all. In fact, very, very similar patterns. On the left, you can see patterns of COVID testing, positivity, cases, and deaths by zip codes in 3 large US cities. Testing is higher social vulnerability of the neighborhood is associated with less testing, more positivity, more confirmed cases, and higher mortality in general. And on the right, again, and this is, of course, very important today, vaccination rates with the only exception of San Francisco, are also strongly patterned by neighborhood social vulnerability index in all these large cities. So a lot of work to do and a lot to think about in terms of what's driving these patterns and what we can do about them. And this brings me to my third fact, which is that the drivers of urban health inequities are structural and systemic. What do I mean by these words? These words are used a lot, so I'm going to provide a dictionary-inspired definition. Structural means relating to the arrangement of and relations between the parts or elements of a complex whole, social structure, economic structure. Systemic relates to the functioning of a system in which factors interact and reinforce each other dynamically. So both elements are important, the structure and the functioning of the system. And this is why urban health inequities are so challenging to address, because they emerge from the functioning of a system that involves many different interacting and reinforcing factors. And I also want to emphasize, and again, to this group, this may not be as important, but I think in the world out there, it's important to remember that these factors certainly encompass healthcare, but they go well beyond healthcare. And in fact, probably these other factors are much more important than healthcare in generating the inequities that we see, although, of course, healthcare is important too. Let me give you an example of what I mean by structural and systemic, and I'm going to use the example of residential segregation because it is one of the key drivers of urban health inequities. So factors like economic inequality and racism work together to reinforce residential segregation by factors such as race and ethnicity or immigration status as well, and social class. This segregation creates inequalities in power and resource distribution across neighborhoods, which in turn reinforce residential segregation. So we have a vicious cycle here that creates large differences across neighborhoods within cities in physical environments, including a range of physical environment features that we will talk about at length during this conference. You see them listed here on the slide, and also the social environment. And you see some examples listed on the slide. And these things, of course, reinforce each other because physical environments affect social interactions, and social interactions and social agency affects physical environment. And so again, here we have another reinforcing loop that is contributing to generating inequalities. All of these things affect more proximal factors, including behaviors, stress, that also reinforce each other and result in differences in health. And of course, these things are operating over the life course and have profound intergenerational effects. So this is why urban health inequities are such a challenge, so important, but also why they require multiple interventions, and also interventions and policies that address their fundamental structural and systemic causes. I just couldn't resist putting in this slide. This came out in the New York Times just a couple of days ago. An amazing descriptive analysis of differences in green space across neighborhoods by income. This is data from the United States. I'm sure we would see something very similar in cities across the globe, showing dramatic differences in tree coverage by neighborhood income. And the fact that these differences in green space coverage are correlated with the history of redlining, which is a practice in the United States many years ago that created areas of disinvestment that were, of course, associated with neighborhoods that were populated primarily by Black people and today by people of color in general. And so the long reach of the past and these structural forces generating very concrete differences across neighborhoods that have major implications for many different things. Of course, temperature, air pollution, physical activity, mental health, etc. So with a pervasive impact across multiple domains. So these urban factors relevant to health inequities, of course, include neighborhoods, and I've talked a lot about that, but they also include many other interrelated factors, which were not on some of the figures that I showed you, but I just want to highlight them: employment, work conditions and job security, housing, mobility and transportation, green space, heat and air pollution, access to services, and they manifest at multiple levels: people, families, neighborhoods, cities themselves, because there's, as I showed earlier, there are inequalities not just within, but also between cities. And they are structural and systemic. So that brings me to my fourth and final fact, which is that because of this complexity that we're dealing with, because of this way in which social structure and systems create health inequities in cities, we need multisectoral approaches to reduce urban health inequities. And this is a figure that we developed as part of the Latin American Network on Urban Health and then Salubal, that highlights some of the global trends, the local urban manifestations of these trends, how this becomes manifest in city and individual neighborhood factors, and how this affects outcomes, health inequities, which also reinforce and are reinforced themselves by environmental factors. Urban policies and interventions are in the middle of this and can really shift the system in one direction or in another direction. By urban policies and interventions, I'm talking about the actions of government, of course, critically important, also the actions of others, both in the health sector, but especially outside the health sector: economic policies and social policy, mobility and emissions control, urban redevelopment and housing, food policy, taxation, climate and environment, water and sanitation, many, many others. Now, in order to intervene, it is critical to have a way of partnerships between knowledge production and policymaking, a connection between knowledge production and policymaking through linkages, through communication strategies, and also, importantly, through the very active participation of the public and other stakeholders. And so this is a challenge to generate and disseminate evidence that's useful, although we all understand that action, we know enough to act, and that often action happens for reasons that are completely unrelated to evidence. But nevertheless, there are ways in which evidence can contribute. In Salud Val, we have a couple of examples where we are trying to do this kind of work, partnering with policymakers to evaluate interventions that are happening for reasons often completely unrelated to health, but that could have health implications, and in particular implications for health equity. And you can hear more about this in panels in the meeting, so I won't go into detail, but I'm just going to highlight two. One is the RUCA study, which is the Programa de Regeneración de Conjuntos Habitacionales. It's an intervention in 2 neighborhoods in Chile that involves dwelling rehabilitation and built environment regeneration, and the team is evaluating a variety of health and environmental impacts. And the other one is Transmicable, led by Universidad de los Andes, which is a new public transport system connecting a neighborhood in the outskirts of Bogota to the central area. And the team is evaluating the impact of this new transportation system on a variety of environmental and a broad range of health outcomes as well. So, to finish up, here are my 4 facts. Cities are characterized by diversity and inequality. Social and racial inequities translated to health inequities. The drivers of urban health inequities are structural and systemic. Multisectoral approaches are needed to reduce urban health inequities. And how do we make change happen? Well, I have no illusion of being able to answer this question on my own, certainly, and I know that this conference will contribute to these discussions, but I want to highlight a few things that I think are important. Certainly, awareness of the magnitude and impact of urban health inequities at multiple levels, I think, remains important because it can be incredibly mobilizing and empowering. So even though we already know a lot, I think continued efforts to create awareness of the relevance of this issue is critical. And certainly COVID has done some of that. Building the evidence base for their causes and consequent policy implications in ways that highlight the systemic and structural nature. new ways of thinking about the causes of health in cities, the links between health and urban environments, and what can be done. We need to break away from the traditional biomedical paradigm, which still remains quite ingrained out there. Bold new initiatives that have multisectoral approaches to improving health in cities and reducing urban health inequities at their core. And there are some examples out there. Hopefully, some of the discussions in this conference will allow us to share some of those examples and also think about new opportunities. Evaluation and tracking of what happens when we do this. This is really important. Demonstrating impact. And last but not least, of course, empowerment and engagement of those most affected is critical for the identification of what we should be doing, for the monitoring of what's happening, and for thinking about how to improve our actions in the future. And with that, I'll finish up. Thank you, and you can find more information on the Urban Health Collaborative and Saruval on this slide. I look forward to the discussion. Thank you very much.
Thank you. Thank you so much, Anna, for a very comprehensive overview. I allowed a little bit more time for Anna to set the stage, because I think it's important that this is the first presentation that really looks at all the elements, shows the complexity of those structural and systemic factors, how they reinforce each other. And it also shows clearly that we need to work with different entry points, multiple interventions, those inequities are made, and they can also be undone. And I think that is also something very important for the next session. I'm sure Nicole is going to be talking more about that. Thank you so much, Anna. So our next speaker is Dr. Nicole Valentine, who will be talking about addressing inequities through a health in all policies approach, a focus on cities. Nicole is currently the Health and Equity Technical Advisor at the World Health Organization in Geneva, Switzerland. She has over 20 years of experience in WHO, where she has led the team developing the global metrics and the survey questionnaires for health system responsiveness, and she has served in the Secretariat of the Global Commission on Social Determinants of Health. She has held positions as acting coordinator, the head of the Equitable Health Systems and Policy Unit, and the Equity and Health Unit. Most recently, her work has focused on developing a learning initiative for countries on addressing social determinants of health and on the COVID-19 pandemic. She holds a bachelor's degrees and a master's of economics from the University of Cape Town, a master's of public health from the University of Washington, Seattle, and a PhD in public health from the Erasmus Medical Center in the Netherlands. Nicole, the floor is yours. If you can keep to 15 minutes, it would be great. Thank you.
Thanks, Jerry. I'll try. I'm very pleased to be here today to talk to the topic of urban health inequities and health in all policies. And in so doing, I'm going to reflect on some of the WHO work, a bit like a story of that work over the past decade or a bit more. Firstly, in our work at WHO to address health equity, we've been fundamentally conceiving of this work from the perspective of the social determinants of health. So from this perspective, we emphasize a lot the role that the health sector needs to play in generating the understanding of the links between structural determinants, so well described by Anna previously, and the patterns of inequities that we're observing in populations around the world, national level and also at the urban level. This really forces us to think about issues related to governance, macroeconomic policies, social policies, public policies, and also culture and societal values. This perspective very early on took us to consider the health in all policies approach. In other words, an intersectoral and multisectoral approach that is described in this slide in the context of the Sustainable Development Goals. For decades, it's been observed that the health sector's budget on prevention is usually around 3%, and that's including immunization. Now, those figures might have changed recently with the huge investments needed for vaccination under COVID, but we're still looking at quite a small percentage relative to the curative care budget on total prevention. And so it really leads us to looking at what kind of in-kind funding, not real funding, but sort of funding through exchange of services or exchange of priorities and policies could be made if we consider that energy, transport, agriculture, labor, and water are also important for health and health equity. In taking this health in all policies perspective, the authors Ramirez Rubio sketched out the targets for each of the Sustainable Development Goals that were specifically related to urban health. And I'm just sort of pointing you to this paper because I think it's quite a very good illustration of the health in all policies approach at the urban level with regard to targets of the SDGs. When we look at large studies of health inequities, we also see the high relevance of neighborhood and living conditions, which have many factors that are under the control of urban leadership or urban or municipal governance. The results in this pie graph show from about more than 20 countries, I don't remember the exact number, but more than 20 countries were analyzed by our WHO European office, looking at the differences in health between the richest and poorest groups in society, and then attributing those differences to buckets of factors. And in the neighborhood and living conditions bucket, we're looking at about 30% of the association of the inequity attributed to this factor. Now, this again is not news to this audience we're speaking with. The many classical representations of inequities by area and by neighborhoods have also been shown using transport maps, like the one shown on the right with the London transport underground system, and then the life expectancy shown at the different stations along the transport network. Similar graphs or similar pictures are available for Washington, D.C., for example. If we break down further health inequity gaps between the richest and poorest, we see topping the list housing deprivation, fuel deprivation, lack of green space, and unsafe neighborhoods. So the issue of health inequities and the social determinants of health inequities really casts a light on how can we do more at the urban level with urban governance, with better housing policies, with better urban planning policies and the like. Now, following the Global Commission on Social Determinants of Health, which concluded in 2008, WHO did put an emphasis on developing data to describe inequities in health for cities, both in health and in the social determinants of health. And that tool was the WHO Urban Heart Tool, which was developed at the time. And on the right, this table 2 is taken from a paper that was published actually fairly recently, about 4 years ago, from Swaziland, where they applied this tool with limited data, focusing on access to safe water and improved sanitation. So if we take a further step back and we look at the world statistics, in summary, we can say that we're in a situation where inequities overall are increasing. And I think Anna's presentation made that point too. I like the statistics presented from the World Social Development Report, where they describe 2/3 of the world's population are living in countries currently where inequality has actually grown. And then reiterating the finding that income inequality is in general wider in cities than in rural areas if you compare those two geographic areas. However, this doesn't undermine the fact that there are important differences in inequalities between rural and urban areas, in particular related to services. And finally, they observed that if we carry on with the rate of progress we saw between the 90s and 2010, it's going to take another 40 years to close the gaps, inequality gaps in stunting between ethnic groups, looking at one dimension of health inequalities. Also, in our work bringing us to the recent days, we've been looking at inequities and the social determinants of inequities related to COVID incidents, morbidity, mortality. And again, if I show you this list from the systematic review that we looked at, you'll see many of them have a resonance for urban governance, for action in the context of urban health. They relate to poverty and deprivation, imposed mobility of low-paid workers in precarious employment, lack of social protection, crowded housing, poor protection at work and low occupational health standards, illegal migrant or resident status, stigmatization, unequal access to acceptable public health information, and inequitable access to affordable treatment, prevention, and vaccination. In WHO Commission on Social Determinants Knowledge Network on Urban Settings, which produced this report, again, I'm looking back now to about 12 years ago, you'll see that many of the issues they highlighted as important for urban settings for addressing health equity remain relevant today, and they reiterate many of the points Anna also made. The only one perhaps missing from this list relates to the climate change challenge. In that same report, they also conceived of packages for addressing health equity. They talked about incorporating health in informal settlements, slum upgrading, targeting the urban poor through better primary health care, strengthening the health equity focus of the healthy settings approach, putting health equity on the agenda of local governments and metropolitan authorities, and pursuing a national agenda for healthy urbanization. And this last issue points to the importance of both strengthening national level support to improved healthy urbanization across countries. Around 2 or 3 years after this WHO report from the Knowledge Network was published, and after the Global Commission on Social Determinants published their report, you saw also references to this work in, I'm taking an example from the European Public Health Association. And in so doing, they would look at lists of what is the local government role in promoting urban health or healthier urban development. Now, everyone probably has their favorite list, but this is just one list to put on the table because it is about having a role, an explicit role in these systems that are generating health inequities. And here the European Public Health Association talked about having the population needs inform the design of neighborhoods and services and facilities, supporting co-production and even leadership for services, supporting the development of social capital, assessing the effects of urban planning on health inequities, prioritizing green spaces. And I love the tree equity report that Anna presented earlier from the New York Times, or I think it was, ensuring fuel efficiency in new developments, but also refurbishments of old developments, regulatory mechanisms, and then exemplar employer commissioning roles played by local governments as well. So in looking at this intersectoral nature of addressing the social determinants of health equity, WHO between 2013 and 2014 put forward a framework for action across sectors, labeled as the health and policies approach, which was defined as systematically taking into account the health implications of decisions, seeking synergies with other policy sectors, and avoiding harmful health impacts. This framework has 6 components to put into action. And examples of some of the implementation actions are shown under capacity building, training the skilled workforce. As an example, establishing the need and priorities for health in all policies through identifying co-benefits and conflicts of interest, for example, framing planned actions, so determining which is the scope of policies, and I think we've seen an enormous scope here already with the 2 presentations, impacting health and health equity, developing or even supporting existing organizational structures for multisectoral collaboration and strengthening the associated accountability, and facilitating assessment and engagement, Sherry in her introduction talked about community engagement, and then also monitoring and reporting, utilizing mechanisms for reporting on measures that are taken that actually improve health and health equity and well-being across government, and not just the health sector's initiatives. We at WHO, we haven't up until now put a huge emphasis at the local level in the health and all policies agenda, but I think that will be changing as we move forward. You will have heard my colleague Natalie Rebel also talking more about the platform that will be developed at WHO. But here are two examples collected by Jay Coburn in a 2017 example. A 2017 paper. We have collected some examples, but I thought these were quite nice. In the city of Richmond, he talks about the Health and Law Policies Ordinance, which became law through urban policies related to access to and qualities of parks, addressing economic inequities related to energy subsidies, land use regulations targeting food security, and also addressing climate change vulnerabilities. He also then cites an example from northern Spain related to a health equity focused impact assessment of a port redevelopment. And I think the important message coming out of that paper is the reshaping of place-based resources and redressing historic spatial inequities, which is very important, I think, to stress going forward. So finally, sort of leaving with two messages, I think it's important in terms of to really look at continued training, continued capacity development in this area. How do we work together, work across different sectors, across different disciplines in order to get the best for equity and for health? And then also to look at building global networks like the one which is being established and supported through this conference, and also there are others which we've been involved in, WHO, the Global Network for Health and All Policies. So those are my closing thoughts. Thanks for the time. Cheers.
Thank you very much, Nicole, for a very interesting presentation. Very much building and on the previous one and in line and deepening. Particularly, focus on the historical focus on social determinants of health, what has happened, and now bringing in the perspective within the context of COVID. Thank you so very much. If you have in general, colleagues and participants, questions, please put them in the Q&A session. So when we have some time in the end, we can look at those. They can also be responded directly by our panelists if they want. I see some direct questions there too, so please feel free to do so. So from Nicole, now we move to the next speaker, which is Dr. Tolula Oni, the founder of Urban Better, the University of Cambridge in the UK. Dr. Oni is a public health physician and an urban epidemiologist, and the principal of Oni et al. And the founder of Urban Better. She is an honorary associate professor and lead of the research initiative for cities, health and equity, RICH, a group of the University of Cape Town, another one from Cape Town, and a clinical senior research associate, a joint lead of the Global Health Research Group at the University of Cambridge, MRC Epidemiology Unit. She's a fellow of the African Academy of Sciences and has had several prestigious fellowships in the past. Her full CV and the full CV of everybody is available online. Dr. Oni is passionate about identifying creative strategies to address complex urban population health challenges in rapidly growing cities globally. Born in Lagos, she completed her medical training at University College of London, earned a master's degree in public health at the University of Cape Town, and completed a doctorate in epidemiology from Imperial College of London, UK. Dr. Oni, the floor is yours. Please go ahead.
Thank you for the kind introduction, and it's a pleasure and honor to be here to share some thoughts with you. In preparing this talk, had a look through who the other speakers are in the session, and not knowing the order, I thought, goodness, if Anna goes first, what am I going to have to talk about? Much less everyone else. So I've taken a conceptual approach, because I thought, you know, and you have delivered so far, Anna and Nicole. So thank you for. I had to have a guess at what you were going to say. So thank you for that. So I'm going to focus on harnessing urban systems for planetary health equity. I'll deconstruct this, firstly focused on urban systems, and then in urban systems of planetary health equity, and then lastly talk about harnessing, the process of harnessing the systems for health equity. So let's go. So getting back to basics, thinking about urban systems, right? So I thought, you know, thinking about, when we talk about urban systems for health, we should start with the basics. So I thought we'll start with the basic elements: fire, air, earth, and water, right? So these are the things that we need to survive, because it is often important to go back to those basics. So earth kind of covers the food and the shelter. Water is obvious. Fire, we think about energy, fuel, heat, light, and air is both the literal and metaphorical breathing space that we need. So those are the kind of core elements that we need to survive. And on the other side of the coin, considering the human activities that we engender in these spaces. So we see population growth and urbanization, obviously, driving with increasing urbanization and migration, both population growth due to cities increasing, but also rural urban migration. We see, particularly in the fastest growing cities, is urban sprawl and this informality that Anna spoke about at the beginning. So when we're talking about urban systems, it is worth us considering how those elements interact themselves and how they interact with the ways that we're urbanizing. And this is another way of showing the changing urbanization that has been talked about. So this is looking at projections of urbanization between 2000 and 2050. And you can see that the fastest growing regions by far are Asia and Africa, and with South America, which is where we are virtually today, being the highest, having the highest urbanization state, so with the highest proportion of people already living in urban context. So that's really important to understand. So whereas in Africa, which is where the majority of my work is based, we're starting from a low baseline almost across the board. The pace and the force of urbanization is really quite remarkable. Put another way, I really like this map because it really brings it home. This is the number of people moving into cities per hour, so the hourly growth. So New York has 11 people moving into cities per hour, as does Atlanta. London, where I'm at the moment, has 10. Compare that to Lagos, that had 56 people moving in per hour. Delhi has 75 people moving in per hour. So you just kind of get a sense of the sheer force of urbanization, and that has significant implications on health, on health equity, and on the strategies for harnessing these systems for health equity. So we've talked about the urban systems, the left side, and looking at how elements, how we kind of pull in the elements in the context of urbanization. We can consider the urbanization process as a kind of metabolic process. So we kind of metabolizing this element into environments. So where we have within the context of the cities, we're metabolizing the elements into energy. We're effecting changes in land systems to shape our food production, to shape our human settlements, our healthcare, our public space, our transport, our waste and water systems. And these are essentially metabolized into the environments that we actually experience. And so in addition to thinking about how these elements interact, in thinking about urban health and the impact on human and planetary health, we have to be thinking about how these impacts interact, how the elements interact with the health impact, and how these exposures and impacts can be harnessed for health. So this is the third bit. So we talked about urban systems. We talked about them being metabolized into environments. And then in thinking about how urban systems, planetary health equity, is important to think about as I'm going to go from left to right, consider our need, which influences the direction left to right, as it were, and the consequences of our actions, which are bidirectional. So going from left to right, and obviously don't try to follow, or pick your favorite thing and follow it. The idea for this was really, when we think about what we need, thinking about and trying to think about the ways that they can be harnessed for health and sustainability. And as I said, with the consequence, trying to think about the consequence of the common anthropogenic processes that we have on health and the environment. You can see that we have urbanization contexts that generate hazards to health. So we have things like food and walkability, access to water, sanitation, healthcare, the sprawl that we talked about on the left-hand side, and how that impacts mental health and physical activity. So you can trace that all the way along. Importantly, and these are encapsulated within, and this is where the planetary health context comes in, is encapsulated within the context of climate change that are characterized by these extreme weather events, rising sea levels, increased land temperatures, which are obviously exacerbated by the tree inequity that was highlighted earlier. We see the ecological disruption, playing a role in biodiversity loss, playing a role in exposure to zoonotic and other infectious diseases. So you can really see that these health implications are interconnected and interdependent. At the right-hand side, healthcare access is obviously a cross-cutting factor that influences outcomes, but has been reiterated. We do know that the majority of the factors that influence health lie outside of the healthcare factor, but obviously access to healthcare is an important aspect to consider in these outcomes. And importantly, when we talk about the health outcomes of the right-hand side, really highlighting two things. The first is a life course. So the continent I predominantly work in, Africa, has a median age of 19. So when we're talking about exposures, urban exposures that impact health, it's important that we're considering the stage at which those exposures are happening, and the opportunities to intervene at different points across the life course. And these are not evenly distributed. So an example is an air pollution study that was conducted by the World Bank in Lagos found that 60% of the deaths related to air pollution in the city were occurring in under fives. Right. So when we talk about the exposures and outcomes, it's important that we're not thinking just human as an amorphous structure, but that we're thinking about the different vulnerabilities. And the second point is inequities, right? And that's racial inequity, that's gender inequity, that's economic inequity, and those have been elegantly shared so far in the first two presentations. But I want to highlight perhaps what I see as the 4 dimensions of equity that whenever we're talking about inequity, we should be thinking about. And that relates to inequity with respect to exposure, with respect to susceptibility, with respect to access, and that's to care and to information, and with respect to consequence. And a great example of this is is what we've seen in the pandemic at the moment, and I won't touch on that significantly because I know Ara is focusing on the pandemic, but in the context of inequity, if we think about where the higher rates of hospitalization, higher rates of mortality are, we see that the inequities in exposure with people with more public facing jobs who don't have sick pay, which speaks to the social side of things, is unequally distributed. When we look at susceptibility, the second dimension, we know that the pre-existing comorbidities that increase the risk of morbidity and mortality from COVID was already unequally distributed with more deprived population groups at a higher risk of pre-existing comorbidity. Access both to care in terms of when you're sick, access to information that is reliable, but also access to social care, to buffer the impacts of so that you're actually able to, say, shelter in place, etc. And then the last point of equity, as I mentioned, the consequence. So what is the consequence of you getting ill? What's the consequence of you staying at home? And that varies significantly in different population groups. So we really have to think about when we the context of those the life cost and inequity, but also thinking about that interaction between the unsustainable urbanization processes that accelerate these climate hazards, that increase the risk of acute shocks like dislocation and even the risk of social unrest, as well as those more chronic stressors that increase both exposure and susceptibility, like poverty and the unequal access to a healthy environment. So when we think about harnessing, is somebody talking? Okay, so when we think about harnessing these systems for health, in addition to considering those inequities, we also have to consider the hazards that are created by the changing climate, the urbanization related risks, and the intersection between this urbanization and climate risks and the socioeconomic vulnerability. Okay, I talked about these already. And importantly, we do need to consider the when and how of implementation. So when we start thinking about harnessing these urban systems for health, the when and how of the implementation is really critical. So just focusing a little bit on the African continent as a way of exemplifying the when and how of the harnessing. This is the last part of my talk. The Africa Union's Agenda 2063 is the master plan for the Africa we want by 2063, and it sets out a blueprint for inclusive, sustainable development. So it was a move from really giving a future direction for the continent. And I'm encouraged by the blueprint because it essentially has planetary health in its DNA. It talks about equitable population health and well-being. It talks about inclusive as urban development, etc. But really the devil is in the detail. And we need to start thinking about a roadmap on harnessing these systems, because the decisions that we make now shape the cities for decades to come. And it never seems to be as urgent a time to act, but it really is a pressing issue. And we know that the transformative action that we need, the systems change that we need takes time, but not just any kind of time. And I want to introduce two concepts that will frame harnessing of the systems. The first is integrated governance, and then the second is the type of time. So with integrated governance, I like to think about this along 3 A's of thinking about the actors, thinking about agency, and thinking about accountability. When we're setting up a timeline for effective change in terms of actors, we consider, well, who's involved, across which sectors, what is the power dynamic are we engaging with? Are we engaging with diverse knowledge sources? Are the youth and the more representative populations being involved, etc.? when it comes to agency, thinking about the features of the system that the actors are working within that can facilitate the integrated action. So things like, are incentives of performance indicators aligned with the desired impact? Is meaningful participation of those actors supported, etc.? And then lastly, with accountability, recognizing that, critical to recognize that impacts can be immediate and short-lived, can be immediate and sustained, and delayed and unsustained. So when we're trying to measure the accountability, do we have a good sense of the nature of the timelines within which we expect to see an outcome? And that needs both acute and protracted responses. But in addition to integrated governance, I want to introduce this notion of time to highlight another ingredient I think is really critical for harnessing these systems for health. I mentioned earlier that change takes time, but it's not just any kind of time. And I'm enamored by the notion from the ancient Greeks of the two words for time, right? So there's chronos, which you recognize from chronological. So that's the fundamental concept of time, the quantity, the tick-tock sort of thing. But there's also the kairos time, which is more qualitative, which is what we describe as the right time or the opportune time, when there marks an opportunity that can't be guaranteed to recur. And kairos has been described as comprising several components, including need to consider constraints within the system to action, and importantly, exigence, which I find is such a critical, I'm still mulling this over, because thinking about what exigence is essentially the drive and urgency to effect change. So that feeling of that pressing notion that something has to happen now. So it's really critical that we think about, well, what are the exigencies of urban systems that demand urgent action? And in this case, I would say that the exigency is the urgency to prevent ill health and to protect the elements that we depend on, they started on. But in order for this to happen, thinking about harnessing the systems, this exigence will need to function as a central organizing principle of urbanization, and that is a sticking point. So I'll end with two brief examples of one of integrated governance and one of kairos time. So using the example of Lagos, I'll show you two sides of Lagos to think about integrated governance and acknowledge my colleagues, Professor Lawanson and Dr. Mogo, who collaborated with on this piece, where we looked at two different initiatives that were climate related, one related to climate mitigation, one related to climate adaptation, and interrogating the opportunity for thinking about integrated governance in this space. So on the left here, we have a mock-up of Eco-Atlantic, which is the plans for a new Dubai type in Lagos. It's pitched as this eco-friendly smart city. It's built on land reclaimed from the Atlantic Ocean and protected by this Great Wall of Lagos, it's called. But the same wall that will protect this smart city could worsen the situation for neighboring areas not protected by it, which is the majority of the city. And those communities and those areas are already at high risk of flooding.
Sorry, 2 minutes, please. Could you start wrapping up?
Okay, yeah. No problem. This is my last, my penultimate slide. So in thinking about that, so in addition to that, it also has privatized public space, which is the very precious public space that people have access to in terms of recreational physical activity. So that is one side of mitigation that had missed the opportunity to engage different actors to understand what the health needs are, what the potential downsides are, and to ensure that an intervention that sounds like a good thing on very superficially in terms of a climate friendly and climate resilient city is not actually widening the inequality. And then the second, on the other side of things, is the Ajegunle Korodu Community Resilience Action Plan. So this is an action plan that was conducted by the University of Lagos team in partnership with the Lagos State to look at the community adaptation strategies. I won't go into it because we've run out of time, but the key things was that it was incredible to see that adaptations are required, but the missed opportunities in considering the links between flooding, health, and healthcare, and the missed opportunities in terms of integrating not just early warning systems for flooding, but early warning systems for water-related outbreaks that are more likely in flooding, during times of flooding, and integrating those. I promise this is my last slide because, and you're going to want to see this. So this is an example of the Kairos time that I was talking about. So in June last year, the Africa Development Institute of the Africa Development Bank convened experts from around the world for a couple of days for a policy seminar to look at the impacts of COVID on health in Africa. And the aim really was to identify policy options that could build a more resilient health and health systems post-COVID. And the outcome was this, or the output was this matrix of policy options. And I've just teased out a couple of things that came out of that, because it identified significant dissonance between development strategies and health planning. It recognized that any plan to so this all ministers should have a planetary health portfolio, which I thought was really radical, but recognizing that all plans any plan such as this would need commitment from governments, from private sector, from multilateral organizations to align performance and success indicators to creating health. Making health everyone's business, adopting a science-based approach that evaluates the health impacts, mobilizing and leveraging new sources of development, and importantly, bringing that accountability mechanisms in an integrated way that I spoke about. And lastly, and critically, the importance of engaging youth as a key demographic whose health the continent depends upon. So I think it's really, I can't imagine this sort of integrated approach happening before the pandemic. And so this demonstrates, going back to that Kairos, that critical, that opportune time for transformative action, is an example of an initiative that seeks to harness that. And I'm really encouraged to see the Inter-American Development Bank represented in sessions at this conference, and I look forward to, and Anna knows we've been talking about exchange and learning between Latin American, Caribbean regions and the African regions, and this really is the critical time. So if not now, then when, I'd say. So let's make that happen. So I'll end there, but before I do, I will abuse my platform to put a plug for the fact that after this session, we have a networking session for the Africa Working Group for the Society. So for anyone working, practitioners, researchers, any organization working within the African continent, interested in pushing this forwards and recognizing Kairos time, I encourage you to join us in that session after this. Thank you.
Thank you. Thank you so much, Tulula. Very, very interesting presentation. And I'm sure there will be many joining you in the next session. And thanks for putting the focus on the right time, if not now, then when, and also putting the focus on the African continent and many other things that I'm not going to attempt to summarize. So thank you very much. So we will have now our last panelist, who's going to speak about urban sustainability and health equity post-COVID. This is Dr. Aroma Revi, who is the director of the Indian Institute for Human Settlements and has over 35 years of experience working on sustainable development, on public policy and governance, human settlements, and global environmental and technological change. He has built the Institute into a world-leading education, research, training, advisory and implementation institution with a focus on multidimensional challenges and opportunities of sustainable urbanization. He's a member of the Lancet Pathfinder Commission, as well as the Task Force on Global Health Diplomacy and Cooperation of the Lancet COVID Commission, and he serves as the co-chair for the UN Sustainability Solutions Network and is a member of the Ubuntu Advisory Board of the United Cities and Local Governments President. And president of UN Habitat Stakeholder Advisory Group, sorry. He is an alumnus of the IIT in Delhi and the Law and Management Schools of the University of Delhi. Dr. Omar, the floor is yours. I see you twice, so I hope there's not going to be an echo, but go ahead, please.
Yeah, I can see myself just once. So thank you, Jerry. It's a pleasure to be here. I'll do something pretty old-fashioned, and I will just speak. I'll try and build on the evidence provided by my fellow panelists, a wonderful arc that we've seen today from Anna to Nicole to Tolu. But I'll be speaking both in the context of COVID, which I think pretty much all of us have experienced and some of us are still experiencing, but primarily on the implementation of the SDGs, the new urban agenda and the Paris Climate Agreement, because they're all coming together, and Tolu's just shown us how you might think of them together when you're thinking about planetary health. Now, when you think of this, and given the fact that we're talking about trying to implement all of this stuff by 2030, and we've had this massive, massive shock at the moment of COVID, this is a huge challenge, not only in terms of scale, I mean, we always knew that, but also both of speed and geographical scale. And just to think of it, we have about 3,500 days to implement this agenda. And at the least, we have to implement it in 10,000 places. Actually, the number of places that are urban in the world are many more, maybe an order of magnitude more. But if you divide 10,000 by 3,500 days, you probably have to really achieve all of this in 3 places in every day from now till the end of the decade. So I think that's the real context that we're dealing with. And COVID, in some ways, the way I've characterized it in some of my writing, is actually the perfect SDG storm. So we built this whole framework, which I'm still not sure about that. Which actually did a whole range of these questions. And what is effectively done is that it started with SDG 3 around sort of universal healthcare, but it's driven national economies into deep recession. It's plunged hundreds of millions of people into uncertain livelihood conditions, which is SDG 8. It's sort of worsened poverty pretty much in most parts of the world, especially in the developing world. And as a result of that, has obviously impacted food insecurity. It's also closed down educational systems. In our country at the moment, we're having a real challenge trying to bring children back into school. It's disrupted public transport, which is all about SDG 11. As demand and real incomes have fallen, it's impacted access to affordable clean energy, which is SDG 7. Access to clean water and sanitation in some places. And of course, the real thing that is not often spoken about is the tectonic fault lines of economic, that's SDG 10, and gender inequality have opened in many, many parts of the world. And the impact of that, of course, is we potentially undone decades of peacemaking and institutional building. That is SDG 16 and 7. So effectively what we've seen here is something that came in from SDG 3 has actually permeated that entire framework in some senses. And I think that's the real question that we're trying to deal with here, apart from the human experience that we've seen and are currently seeing in many parts of the world. So if you look at it structurally, we have a deep challenge here. And how does it play out in a country like ours? I mean, in India, this started as a rich person's disease, brought in by air travelers from foreign lands, but it has exposed all the fault lines in society, economic systems, and health systems in just under 18 months. At the moment, our official figures are 400,000 people dead. Actually, the estimates are maybe 3 to 4 times that number. 200 million people falling into poverty. This is the most dramatic falling into poverty that we've probably seen in the last 50 years or so. There are about 10 million people in the informal sector from cities who walked home during the largest economic lockdown in human history. So essentially what's happened is, because of this fundamental sort of inequalities between cities and other rural areas, India is still a third urban and 2/3 rural, and inequalities within cities, you're seeing a decimation of many segments of the economy. And of course, the interesting and the contradictory thing in some ways is that income and wealth inequality has actually increased. So, we heard about, and that the World Social Development Report talks about inequality increase in the long run. But in the last 18 months, in a country like India, which has the largest proportion of poor people in the world at the moment, we've had a dramatic increase in income and wealth inequality, as people who have wealth and privilege have actually become more endowed and richer in some senses. So I think one of the core questions that we have to ask is, in the current context, post-COVID, will we be able to achieve SDG 3? Or in fact, pretty much all of the other SDGs by the 2030s? Or do we actually have a setback by a decade or more in parts of Africa, Asia, and maybe Latin America, and especially in the urban areas in these regions? Because that's where, in some senses, the concentration of these challenges have been seen, have been experienced, and are still currently playing themselves out as you go from wave 2 to wave 3 to, hopefully, the world can get its act together, and we have sort of universal vaccinations by 2022 end. There's a long way to go between now and the end of next year. So I guess one of the core questions that we ask ourselves, we know about the really bad news about the pandemic, but is there some good news? And of course, there are many interesting and important things that have happened, including the fact that in some cases, science is sort of taking the lead in interventions and processes. But I will sort of pick up on just two sort of things that I think are fairly important. The first thing is, unlike the claims of national government and the struggles and the confusion of the international system in dealing with this question, local governments and communities in many parts of the world, and obviously I know this concretely from our own context, but many of us are in touch with processes happening across the world. Local governments and communities have led the charge in dealing and responding to COVID, in all its elements. And in many cases, I would say, and of course, the literature will show us how this has worked in time, they've done this more effectively than many national governments. So that's, I think, a very important thing. The claim that we can deal with these things only with national governments, that's what the SDGs were framed around, may actually come into deep contest just now, as there's a lot of bubbling up of innovation of process and real delivery on the ground at the local level. The other thing that I think COVID has shown us very clearly, because I do a fair amount of work on climate, and one of the biggest challenges in climate is trying to deal with questions of behavior change. How will you consume less? How would you, deal with questions of emissions and stuff like that? And I think what COVID has showed us is that behavior change at scale is possible, and it's possible at really, really rapid paces. So, it may not hold for very long, as we're seeing in many cases, but it's certainly possible to actually influence hundreds of millions of people, of course, sometimes with rather draconian measures and not very, very good options. But that is something that's really important. So I think the questions of, a whole suite of new opportunities that have come to us out of this are actually good to look at. So having sort of said that, urban health inequality, inequities are not only driven by, as we've heard so well articulated with my co-panelists on this, driven by questions of access, affordability, health-seeking behavior, social determinants, etc. But it's centrally linked to a range of fundamental questions on the nature of the city or urbanization. And that's what I kind of want to deal with in the rest of my comments on this. So cities, we know, concentrate opportunity, better infrastructure, better services, environmental services, health services, etc., at lower cost because of economies of scale. They concentrate opportunity in terms of livelihoods, which raise income, improve nutrition levels, and hopefully, in many parts of the world, in time at least, access to health services. But they also concentrate economies of scope, so access to education, to information and knowledge, and we've seen that really working very effectively. If you look at sort of emergency response systems and dealing with, oxygen crisis, which were in India not too long ago and are now running through Indonesia and many other parts of the world, it really is these economies of scope and scale that create the opportunities that we see in urbanization. But there's also another thing, what I call, in a sense, a dark side of urbanization. So cities historically and even now concentrate four things. They concentrate poverty, absolutely, at least in the regions of the world where things are dramatically changing, and of course in the south and the global north. So they concentrate poverty, they concentrate inequality, they concentrate risk, including, of course, of pandemics, and that's sort of the history of in a sense, disease in some senses, and they concentrate conflict. And these four things are very closely tied to each other, especially in situations where things get out of hand in urban systems. And in some ways, inequality is one of the most sort of driving forces of sort of economic success and opportunity in cities. And this is in all its dimensions: income or class, gender, race, ethnicity, and it manifests itself in very concrete ways in real places, in informal settlements, in ghettos. This is sort of all of the underbelly of urbanization that's there. And this is not new. This is, I would say, pretty much as old as the history of urbanization. So in a sense, what I'm saying is that inequalities in cities is one of the core drivers of inequality in health systems and health access. So they're sort of tied to each other in some ways. And the other thing, of course, is there's been this wonderful sort of mythology over the last, 150 years or so of the city as a melting pot. And that's true maybe in some parts of the world. But if you look at where the bulk of sort of the emerging urbanization is going to come in parts of Asia, in Africa, and of course the struggles that we've seen in Latin America over the last 50 or 60 years, and that is that this mythology of the melting pot overcoming economic inequality, social inequality, and dealing with questions of environmental justice is actually not borne out by the evidence. So in most parts of the world, whether it's the global south or the north, this question of the city as a place that's actually being able to address questions of economic justice, social justice, and environmental justice, and hence health, sort of health inequality or health equality is not necessarily held out. And I think we need to look at this very, very critically. So while we know that life expectancy has increased in most countries, the disease burden has reduced and maybe shifted in some places, and some places have provided near universal access, the fact is, if we do not address underlying social and economic inequality, health inequality will persist, and at least in our experience, be reproduced not only from one generation to the other, but also across urban systems. And I think, COVID has shown that to us in very, very graphic terms. So in some senses, when we're trying to interrogate the 2030 sort of agenda or the new urban agenda, I think the harsh or the sharp question to ask is, can we really say that by the latter part of this decade, that no one will be left behind? I think that's that's a core question in some senses. And then more pertinent for cities, of that 10,000 places or the 200,000 places, if you take smaller spaces across the world, that no place would have been left behind. I think that's the question that we have to ask. And when you start doing that, I guess the most obvious thing is, if we need to address inequality in health systems, we also have to address the roots of inequality in social and economic systems across not only the metropolitan cities and the million cities, which is what most of us actually research and work on, but also in the smaller spaces, in the secondary cities, where the bulk of these processes will be played out in the next 20 to 50 years or so. And eventually, of course, in the towns and the villages, because there's a continuum here as far as urban systems are concerned. The other question, and I won't deal with it very much, is what Tolo's spoken about, and the relationship between human well-being and ecosystem health. Cities have a voracious appetite for ecosystem services, food, water, air, etc., primarily because of their industrial metabolism, and hopefully that will be changing. But they're also primary drivers of air pollution and water quality. So healthy cities need healthy regions, and a very different relationship between urban systems and the countryside or the regions in which they're situated. So you can't have inequitous urban systems if you also don't look at regional inequality and what large urban systems actually draw out and put back into the regions in which they're situated. So having said that, how can we think about addressing the structural drivers of urban health inequality? I think the most obvious thing is we have to organize. I'm just wrapping up just now. We have to organize and prioritize the implementation, not only around SDG 3, around universal healthcare, but around SDGs, all the SDGs in urban areas. Of course, urban health and education will need to be rethought as far as it's concerned. But if we don't look at the entire system, if we don't look at poverty, we don't look at water and sanitation, if we don't look at ecosystems health, I think we're going to be in pretty serious trouble. And the other thing that COVID has really shown us very clearly is we do need to rethink universal access to very basic questions. Food security, because it has a direct relationship to nutrition. Basic urban services, because it has a direct relationship with environmental health. And social security, because that's the only way that many communities will actually be able to deal with the fundamental inequalities that they're born with, and hopefully, they will not necessarily have to die with. Some cities are actually going even further in COVID to explore livelihood security and a basic, income entitlement. And that's, I think, the frontier of this process of trying to look at what the underlying drivers of what are traditionally called the social determinants of health are, and how that's going to happen. Now, how will this happen in practice? I think the hard-nosed thing is that it can't happen unless our green investment stimuli, whether it's in affordable housing or upgrading or building resilient health and social infrastructure, actually integrate into them some of these key concerns and principles. And unfortunately, even in the global north, if you look, and I've looked relatively closely at sort of the Green New Deal in Europe and in North America, the integration of these questions that we've dealt with in this session is actually very weak, and the money is, in a sense, not where the mouth is in some senses. So I'll stop there, and thank you so much for the opportunity.
Well, thank you very much for another very interesting presentation. I think the 4 presentations really were fantastic, and they complemented each other perfectly well. Unfortunately, we have no time for questions, and I also will not attempt to do a full summary. I think we've heard from the different perspectives about what the situation is, how we have arrived, where we have arrived, how COVID has exacerbated the situation, has exposed those vulnerabilities, but also has provided us this opportunity. And I think that that's the part where we usually stop. And I think, we have an opportunity here also over the coming 3 days to really look at and pick out the things that you have been mentioning about, their regional initiatives, their national initiative, but particularly also city initiatives that are trying to build back in a different way. We've seen that intersectoral processes have flourished where they didn't before the pandemic. We've seen, and we've just heard also, that local governments have taken in many occasions a forerunner role. The communities have been extremely active, very often because they had to be, because there was no response that was good enough, and that was protecting them from what was happening. But we've also seen that the responses are not going far enough, and that there is this risk also of losing this opportunity that we're having now. And I think that collective thinking and the collective brain power that we have here over the coming 3 days to think about what is the opportunity for our cities, what are the political scenarios necessary for that, what are the lessons learned from the different regions and the different countries, the different cities, the different communities, localities. That's, I think, we're going to have a lot of interesting discussions, and hopefully when we come to the last session, we will be able to come with some recommendations, some conclusions, some way forward that you have already started to map out and to highlight. So I really want to thank you. I think this was a fantastic panel, and unfortunately we won't have time to go further in the discussions, but I'm sure we will meet in the different panels. And thank you so very much, and see you in our next sessions. Thank you very much.
Thank you.